Well, guys, today we're going to talk about the cardiac output and how it's related to venous return and how can they be regulated in our bodies. And this is part two of the lecture. Okay, so first of all, let's talk about cardiac index. Now, cardiac index, basically, in a simple words, is talking about cardiac output. Now, cardiac output, in relation to your body surface. And it's going to be affected by four things: metabolism, exercising, age, and body size. So, depending from person to person, when you compare these factors, according to this, you're going to have different cardiac outputs. So, for example, an athlete or a runner, for example, that runs every morning is going to have a different cardiac output than someone who's just always at resting position. They're not really exerting a lot of work, a lot of force. Why? Because their tissues, this athlete, his tissues demand more oxygen and therefore demand more blood to be received to the tissues. And now the second point that you need to know is that the cardiac output is always going to be equal to the venous return. What does that mean? If you have an increase in the venous return, that means that you're going to have an increase in the cardiac output. A decrease in the venous return is going to decrease the cardiac output. So ultimately, cardiac output and venous return are directly proportional. Okay? Now moving on to a really big objective of this lecture, which is the Frank-Starling law of the heart. What is it saying basically? It's telling you that we have factors that are going to affect the cardiac pumping. When we say cardiac pumping, we are referring to the cardiac output. What does your heart pump? It pumps blood. So an increase in cardiac pumping means an increase in the cardiac output. Now you have three things that are related to the Frank-Starling law. What are they? Increased venous return, stretch of the SA node, and stretch of the atria. Now to remember this, relate them, and you have a stretch of two things and an increase of something. What is this increase? It's the venous return. Why? Because venous return and cardiac output are always related. And if you have a stretch in the atria as it's filling, obviously you're going to have a stretch in the SA node. Why? Because the SA node is in the atria. Okay? Now, if you go back to the previous lecture, it's going to mention the Bainbridge reflex. The Bainbridge reflex is triggered by the stretch of the atria as the baroreceptors present on the atria. You're going to sense an increase in the volume, and this is going to trigger the Bainbridge reflex, activating the sympathetic activity, and therefore increasing the cardiac output. Now let's look at this picture that I think the doctor drew. What is happening here? Basically, this is summarizing everything for you. So if you keep this in your mind, you basically have these three done and explaining the Frank-Starling law of the heart. What is happening? You have the superior vena cava, inferior vena cava. They're bringing the blood, they're holding the quote-unquote venomous return that is going into the right atrium. Okay, so you have a volume of blood that's going into the right atrium is stretching this atrium. Now, this is gonna trigger the Bainbridge reflex. What is stretching with the atria? The SA node. Now, the Bainbridge reflex, which is a nervous regulation, is activated. Sympathetic activity starts and leading to a higher cardiac output. Why? Because sympathetic activity is going to increase the contraction of the heart, pumping more blood. Okay, so venous return is high, coming from the right, from superior vena cava, inferior vena cava, entering the right atrium, causing a stretch of the SA node and the atria. Baroreceptors sense this, Bainbridge reflex activated, sympathetic activity, high cardiac output. We're done with this Frank-Starling law of the heart. Now, moving on. When we say cardiac output, what are we saying? Now, logically, we're talking about the blood that is being pumped out of the heart, going to all of your body, and then going back to the heart, and it's just a whole circulation. You already know this. Thus, as a definition, it is the total tissue blood flow. All the blood flowing in your tissues, we call this cardiac output. Okay? Done. Now, we need to know that cardiac output is proportional to something, and it's inversely proportional to something else. What is it proportional to? Cardiac output is proportional to tissue oxygen use. What does that mean? In simple words, it means that this tissue's particular oxygen demand is gonna dictate how much blood, how much cardiac output it's gonna receive. So if someone's exercising, right, their tissues is consuming oxygen. So therefore, they need oxygen, right? And this decrease in oxygen is gonna tell your body, hey, I need blood here. I need blood to reach here. So the higher the oxygen demand, the higher the cardiac output reaching that tissue. Okay, so we're done with this first point. The second point, the cardiac output is inversely proportional to the TPR, which is the total peripheral resistance, which is basically the resistance in the veins. Uh, so that means that if you have an increase in the TPR, your cardiac output is going to be decreased. Okay, and this is when the AP, atrial pressure, is constant. Now your atrial pressure is usually around zero. Okay, and this brings us to the last point in this slide, which is cardiac output is equal to MAP minus RAP. RAP is the right atrial pressure divided by the TPR. And why do we need this? You need this to rearrange it to make the equation that we're going to talk about later in the slides, but I'm going to leave it out for now, so it'll all make sense towards the end. So in this slide, you need to know that cardiac output is proportional to your oxygen need in your tissues, and it's inversely proportional to the TPR in your body, in your veins. Okay, now remember the concept that cardiac output is proportional to oxygen use. We're going to demonstrate this onto a graph. Why? Because us on this whole lecture, basically is slides and words, sorry, graphs and words. Okay, so let's look at this graph. You have the work output during exercise, and then you have the cardiac index, which is, in other words, the cardiac output. Then you have the oxygen consumption. So here you have a couch potato, which is basically somebody that doesn't work out. They're always, they're not really an active person. They're just your average human being. And then you have an athlete who's always on the run, always exercising and whatever. As you can see here, for someone that does not exercise and is not physically active, their oxygen consumption is low, right? So therefore, the cardiac output is going to be low. Why? Because cardiac output is proportional to tissues, to oxygen tissues. Oh, logically, if you think about it, somebody who doesn't exercise as much, their tissues is not going to be in demand of oxygen because it's not going to be hyper consuming this oxygen for you to need more blood. However, in athletes, they're consuming high amounts of oxygen, and therefore they're going to need more cardiac output. So you can think of it logically, or you can relate it to the cardiac output explosion to tissue oxygen use. Okay, so this is the first. This is what this slide is talking about. And here you have a second graph for the second point that cardiac output is inversely proportional to the total peripheral resistance. Right here, if you look at the graph, it's giving you a bunch of diseases or abnormalities in somebody's heart as comparing it, the cardiac output to the total peripheral resistance. Now, what you need to really know and remember from here is beriberi. Now, let's focus on beriberi, and then we can talk about AV shunts and hyperthyroidism because they're um equally important. Now, I'm not going to tell you what's important or what's not, but I'm telling you what the doctor has emphasized during the session. So let's talk about beriberi. Beriberi, the TPR is very low. Okay, the TPR is low, but your cardiac output is very high. Aslan, it makes sense because we said that they're inversely proportional. So TPR is low, your cardiac output is insanely high. Okay, so this is beriberi. And then AV shunts, same idea. Hyperthyroidism, same idea. And in normal, as you can see, your total peripheral resistance is normal and your cardiac output is also normal. It's about 5 liters per minute. And then you can uh, compare it to hypothyroidism, where you have extremely high TPR and therefore really low cardiac output, about 50% only of your normal cardiac output, which is about 2.5 liters. Okay, so basically this is what the graph is talking about. And remember the try to memorize the diseases or the abnormalities that are related to these conditions. Okay, now your heart can act normal. So right now, I'm just talking, I'm sitting, I'm not doing anything. It's at normal, okay? However, our heart normally has to be hyper effective, and sometimes, which is bad, it's hypoeffective. And keep in mind that it's not always good for our heart to be hyper effective. But sometimes, for example, when you're exercising, you need it to be hyper effective. You need more cardiac output or venous return in your heart to compensate for the oxygen consumption in your body. Okay, now think about it. What would cause your heart to be hyper effective? Number one, sympathetic activity. If you trigger sympathetic activity to the heart, what is going to happen? Increase in the heart rate, and you're going to have a higher strength and contraction and pumping of the heart. So basically, your heart is going to act as a much, much better pump due to sympathetic activity. Number two, relate this to athletes. Heart hypertrophy. What is happening? Your heart is bigger, it's dilated, and it's almost double the size. So if something is bigger, it's going to have higher strength of contraction. It's going to be much stronger. Again, you can see this in athletes. Have heart hypertrophy immediately relate to athletes. Okay, so if you combine these two, on average, your cardiac output is going to be about 40 liters per minute, which is a very big amount. And you can see this here. They mentioned the example of marathon runner. Okay, and if you look at the graph right here, at normal conditions, compared to hyper-effective, you're going to have a much higher cardiac output. Okay, now causes of a hypoeffective heart. Hypoeffective heart, your heart is not a great pump for your body right now. Like, okay, what causes this? Why is it hypoeffective? This is due to a very high increase in the atrial pressure. Okay, but what does the pressure have to do with that? Because your heart needs to push against that pressure, right? So if it's very high, your heart is not going to be able to do that. And therefore you're not going to have uh blood pumping in your body. And you can see this in severe hypertension, increased pressure, blood pressure in your body. Another reason could be inhibition of nervous excitation of the heart. So we talked about how we use sympathetic activity, right, to excite the heart. So if you inhibit that, the rate of contraction is going to be really low. It's going to weaken your heart. Lastly, we're going to talk about pathological factors. So if somebody has a disease, obviously it's going to affect their heart activity. What are these diseases? You have coronary artery blockage, which causes heart attack, valvular diseases, inflammation, infections of the heart, and cardiac hypoxia. Cardiac hypoxia means that your heart tissue is not receiving enough oxygen. Okay, so right in this graph, again, we're back to graphs. It's basically showing you um, the diseases that have a hypereffective heart and the diseases that have a hypoeffective heart. The hypereffective heart, beriberi. When someone has beriberi, they have a hypereffective heart. AV shunts, hypothyroidism, and anemia. And someone who has a hypoeffective heart, meaning their cardiac output is really low, like cardiac shock or traumatic shock. Oh, and now add to the equations. I think this was mentioned in previous lectures, but again, keep it in mind that cardiac output is equal to arterial pressure over total peripheral resistance. What does this equation basically tell us? That cardiac output and arterial pressure are directly proportional. Cardiac output and TPR are inversely proportional. So what information have we added here? That cardiac output and arterial pressure are directly proportional. So an increase in the cardiac output or an increase in the arterial pressure is going to give you an increase in the cardiac output. Okay, so here's just telling you what is venous return. Venous return is the blood coming from the superior vena cava, inferior vena cava, and emptying into the right atrium. Okay, now this venous return, it has to be regulated. Our body is all about regulation and homeostasis. We need to keep homeostasis going on. You don't want too much venous return when you don't need it, and you don't want too little venous return, which can really affect your tissue and heart activity. What are the three things that are going to regulate the venous return? Right arterial pressure. Why do you need this right arterial pressure? Because it's going to exert the backward force that's going to force the blood into the right atrium. Because if you don't have the right atrial pressure, that's without this force, it's not going to go into the right atrium. Second is the degree of filling of the systematic circulation. Why do you need the degree of filling? Because this degree of filling is going to determine how easy is the blood going to flow into the heart? Is it even going to flow into the heart? So keep that in mind, the degree of filling. Lastly, the resistance to blood flow. Now, depending if the resistance is high or low, it's going to tell you if the blood is even moving in your body or going into the heart or reaching the right atrium. So these three are going to regulate the venous return, and any changes in these or fluctuations is going to affect the venous return and therefore affecting your cardiac output. So what are these three? RAP, degree of filling, resistance to blood flow. Now let's focus on right atrial pressure. Okay, so in this graph, when we look at it, we have two things highlighted here, a plateau and the mean systemic filling pressure. Let's talk about the plateau first. What do we have a plateau? Plateau is um due to the collapse of the large veins that are entering our chest. Why are they collapsing? Because you have an increased negative pressure in the right atria. This negative atrial pressure in the right atria is going to suck the walls. It's like a vacuum. It's going to suck the walls of the veins, causing them to collapse and cutting off any blood flow that's going to go eventually into the right atria. So خلاص, and it's like this is your limit. I'm already filled. I don't need any more. Walls collapse. So this is your first point. We're done with that. Now, the mean systemic filling pressure. This is basically a value that is related to the right atrial pressure. Once the right atrial pressure reaches a value of 7, we now call this value the mean systemic filling pressure. And here the venomous return decreases to 0. So at this point, when the right atrial pressure is at the value of 7, we call this mean systemic filling pressure or PSF. Okay, and the venous return at this moment is what? It's 0. Okay, so here you need to know two things: what causes the plateau in the venous return, and what is the mean systemic pressure, which is PSF. So PSF is 7, and the venous return is 0, and the plateau caused in the venous return curve is due to the collapsing of the walls of the veins. Okay, now here basically you need to know 5 important things. Okay, 5 points. If you've got that, you've got basically what the slide is saying. Okay, so basically, number one, the big idea, okay, which is highlighted in the red box right here. Okay, think about it as an equation. And like physics, okay? You have something called the pressure gradient for venous return. What is it? It's basically PSF minus RAP, which is right atrial pressure. The difference between these two values, okay, is gonna determine the amount of venous return. So if the greater the difference between these two, the higher the venous return, and the lesser the difference, the lower the venous return. Okay, so the difference between these two values, the PSF and the right atrial pressure, is going to degrade the venous return, and we call this concept the pressure gradient for venous return. Okay, that's number one. Now, number two, the difference between these two values must be positive. Why does it have to be positive? Because so blood can flow. If the value is negative, blood is not going to flow. Okay, so this is point number two. Now, let's go back to the regulation of the venous return. Remember when we said that the degree of filling has to do with the venomous return? Now, it brings us to this point. The greater the degree of filling, the easier it is for the blood to flow into the heart. So the more the atria is filling, the easier it is to flow into the heart, and vice versa. If the atria is filling low, if the degree of filling is low, then it's going to be much harder to push it into the heart. Okay, now we have the last point here on the graph. Okay, so on this graph you have venous return, right atrial pressure, right? Here what we need to focus on is right and left shift. When is this graph going to shift to the right, and when is it going to shift to the left? It's going to shift to the left, to the right when the venous return is increasing. So as you're increasing the venous return, it's shifting to the right. If you decrease the venous return, it's shifting to the left. Okay? So basically, this is what you need to know in this slide. And really focus on the graph, try to depict it, play around with the values just so it sticks in your mind. And make sure to remember the right and left shifts and what causes it. Now, resistance to venous return. Now, when we say resistance, what are we saying? Think about it as a fight. You have resistance that is fighting venous return. If this resistance is very high, okay, that means that the venomous return is losing this fight. It's not going to be able to enter. It's not going to be able to move. If this resistance is low, then it's going to be easy for the blood to move. Okay, now here, what do we have? I think it's a patient, I'm guessing, like a human or an animal, whatever, it doesn't matter. But here we have, it's depicting the compensatory effect that would happen to someone that has a blood infusion. Now, blood infusion here is the imposter. It's not supposed to be in our bodies, okay? We have our own blood. So if you add this blood into someone's body, what would happen? How would your body fight this to bring back your cardiac output to normal? Now, normally this takes about 10 to 40 minutes, right? So, how is it gonna regulate it and bring it back to normal? Number one, you're gonna start with filtration. Who does this filtration? We already know that the capillaries are gonna do this, and this is due to what? To increased pressure. So, increased capillary pressure is gonna lead to filtration. Number two, you're going to have a decreased PSF. Number three, increased resistance to venomous return. Okay, so the compensatory effect due to an increase in the blood volume, aka blood infusion, is increased capillary pressure, which is going to lead to filtration, decreasing the blood volume. Uh, Decrease in the PSF due to stress relaxation, and then increased resistance to venomous return. And this is made by autoregulation. Okay, so these are the three factors that are going to compensate for an increase in the blood volume. They act immediately. These are the first three to act. Okay, now we come to here. We have this is the last 2 points, like two objectives of our lecture. You have the effect of sympathetic stimulation and effect of the sympathetic inhibition on the cardiac output. You have graph, and on each point, it's telling you what is happening, and then we're gonna talk about the AV fistula. So first, let's talk about the sympathetic stimulation on the cardiac output. Okay, now let's see the changes that would happen to your cardiac output when you stimulate sympathetic activity. So you're going to notice changes on two sides, on the heart and on the systemic circulation. So first of all, you're going to observe that your heart is going to be a stronger pump. It's going to pump more blood. So the cardiac output is going to be higher. Second, your systemic circulation, the PSF in your systemic circulation is going to increase. Why? Because your veins are contracting, and this increases the resistance to the venomous return. So let's look here. At normal conditions, you have zero right atrial pressure and a cardiac output of 5. This is the normal. Now you have a stimulation of sympathetic activity, right? So what is going to happen? Notice, this is really important, that the right atrial pressure is still zero despite the increase in cardiac output at point C. So it's the cardiac output increased, right, to about 7 liters, and your right atrial pressure is still at zero. Okay, so what is happening? Your heart is working as a stronger pump, pumping more blood and therefore more cardiac output. And number two, the effect on your systemic circulation, the PSF is going to increase, the resistance is going to increase, and the contraction is going to increase too. Okay, then you're gonna keep observing that as the sympathetic activity is getting stronger, you're gonna have maximum sympathetic stimulation. And when is that? That is when your PSF is at 17 millimeters of mercury and your cardiac output is around 25 liters per minute. Okay, so here, when you have sympathetic stimulation, we said your heart is going to be a stronger pump, pumping more blood. So about double the amount. This is number one. Number two, your systemic circulation is going to be affected. How? PSF is going to increase, the resistance is going to increase, and this is due to the contraction of the veins. At maximum sympathetic stimulation, what are the values? You have PSCF is going to increase to 17 millimeters of mercury, and at this time, your venous return is going to be zero. Okay, so this is what will happen during sympathetic stimulation on the cardiac output. Let's come here to the graph. So at point, we need to focus on point A and D. This is what we're concerned about. Point A is your normal conditions. It's at zero atrial pressure and 5 liters per minute of cardiac output. This is normal conditions. Now you are using sympathetic stimulation. What is happening? We are noticing that the right atrial pressure remains at zero, hardly changes, but the cardiac output has doubled, 100% increase to 10 liters per minute. And you need to know the physiological changes happening. As we said, we're repeating again, you're going to have changes on the heart and changes on the systematic circulation. The heart is a greater pumping more contraction. Systemic circulation, increased PCF, increased resistance. Okay, done. Now moving on to sympathetic inhibition. When can you see sympathetic inhibition? In spinal anesthesia and when the patient is using drugs such as hexamethonium. Okay, so this is also depicted on the graph. Spinal anesthesia. What is happening? We're going to have a fall in the PCF. So if we follow the graph here, it's going to be at point B. What is happening? You're going to have a fall in the PCF to about 4 millimeters of mercury, and the heart is not as great as before. It's going to decrease in effectiveness by 80%. 80% decrease in the effectiveness. This is really horrible. And your pumping activities, your cardiac output, is going to decrease by 60% of normal. So let's say, for example, this is not realistic, but yeah, just to make it simple maths, let's say that the normal person is pumping 100 liters per minute. Once you inhibit sympathetic activity on the heart, it's going to go down until 60%. So 40% of that is gone. So 40 liters is gone, and you're left with only 60, and the normal is 100. So this is a very big decrease. Okay, so when you inhibit sympathetic activity, logically your heart is going to be now a weak pump, and it's the PCF is going to fall to 4 millimeters of mercury, and the horizontal is as effective. It decreases to only 80% of normal, and the cardiac output decreases to only 60% of normal. Where can you see this? In total spinal anesthesia and drugs such as hexamethonium. Okay, now we're going to talk about the atriovenous fistula. Okay, now this is the same as the sympathetic inhibition and stimulation. We're talking graphs. We're talking circulatory dynamics. Okay, now first we need to understand what is an AV fistula. It is when you directly open a large artery to a large vein. Okay, you open them onto each other. So here on the graph, on point A, you have normal conditions, zero atrial pressure and 5 liters of cardiac output. Now let's go to point B. In point B, what's happening? Here you open the fistula. You open the fistula. Okay? So what is happening? Number one, you're going to have a rise in the venous return curve. It's going upwards. Okay? It's very clear here that it went up. Notice how the cardiac output is about here like 13, and the atrial pressure went up to about 3. All right, so the venous return curve has went up. You have an increase in the cardiac output, and you have an increase in the right atrial pressure. So here it's saying that the net result on point B, due to opening the fistula, is an increase in the cardiac output. You went from 5 to 13, and you went from 0 to 3 in the right atrial pressure. Okay, so this is the changes from point A to B. This is when you open the fistula. Now, moving forward, what's happening at point C? At point C, the cardiac output is rising even more to 16 liters per minute, and the right atrial pressure rose by 1 to 4. All right, so first we went from normal 5 liters, 0. And then we went to 13 liters, 3. And now we're at 16 liters, 4. All right. Now, lastly, at point D, it's even increasing more. Point D, you have 20 liters per minute of cardiac output, and your right atrial pressure is at 6 millimeters of mercury. So this is the effects of opening a large arteriovenous fistula, and you can see this depicted on the graph right here. At point A, we are in normal conditions. Point B, we're slightly rising, and C, D, it just keeps rising even more and more. And what's acting on this? Sympathetic activity does play a role in this. So yeah, I think, yep, this is the end of our session here. I hope I've helped and that my explanation was good enough. And yeah, good luck on your finals.